today we are going to talk about pulmonary hypertension. We will cover definition, subtypes, groups of pulmonary hypertension, pathophysiology, clinical presentation, diagnosis and differential diagnosis, treatment approaches, and core pulmonale. So first of all, what is pulmonary hypertension? It's elevated mean pulmonary arterial pressure, more than 20 millimeter of mercury at rest, while taking into account that the normal mean pulmonary arterial pressure is ranging between 10 and 40 millimeter mercury. It can be divided into five groups based on the underlying causes. Pulmonary arterial hypertension, it's a type of precapillary pulmonary hypertension. It's characterized by a loss and obstructive remodeling of the pulmonary vascular bed that results in increased pulmonary arterial pressure. So, the pulmonary arterial hypertension is a cause of pulmonary hypertension. However, not all pulmonary hypertension is caused by pulmonary arterial hypertension. Subtypes. So first of all, you have to know the general classification. Like in clinical practice, based on the etiology, we can classify it generally as precapillary and then postcapillary. So for the precapillary pulmonary hypertension, it involves increased pressure from the pulmonary vascular resistance before blood reaches the capillaries. That's why it's called precapillary. It's often caused, for example, by chronic lung diseases, pulmonary arterial hypertension, chronic thromboembolism, or some certain multifactorial mechanisms. And postcapillary pulmonary hypertension, it stems from the left heart disease, so it causes elevated pressure after the capillaries, which leads to increased pulmonary venous pressure. So, for the key diagnostic feature of pulmonary hypertension is right heart catheterization. So, for precapillary pulmonary hypertension, it shows increased in the pulmonary vascular resistance, which is due to a remodeling within the pulmonary vasculature, and decreased pulmonary capillary wedge pressure. While for the postcapillary pulmonary hypertension, it shows a normal pulmonary vascular resistance and it shows increased pulmonary capillary wedge pressure. Now the groups of pulmonary hypertension, as I said before, it can be divided into five groups. So the first group is called pulmonary arterial hypertension. So it can be either idiopathic or it can be hereditary, which has a poor prognosis. It can be drug-induced, for example, like methamphetamines. It can be also associated with other conditions like connective tissue diseases, portopulmonary hypertension, congenital pathology. For group 2 pulmonary hypertension, it's called left heart disease. It can be either associated with congestive heart failure, valvular pathology, or other congenital or acquired heart diseases which are causing postcapillary pulmonary hypertension. For example, like hypertrophic cardiomyopathy, including obstruction of the LVLT, aortic coarctation, hypoplastic left heart. For group 3 of pulmonary hypertension is called chronic lung diseases group. It's associated with obstructive lung pathologies like COPD and obstructive sleep apnea, restrictive lung pathologies, high altitude pathology like high altitude pulmonary hypertension is called, or other pathologies like developmental lung disorders, mixed obstructive and restrictive lung diseases. Group 4 of pulmonary hypertension is pulmonary artery obstruction group, which can be either, for example, like a chronic thromboembolic pulmonary hypertension, which can be also including compression by presence of some tumor like mediastinal tumors or masses, or for example arteritis involving the pulmonary arteries, or it can be a congenital stenosis of the pulmonary arteries. Group 5 of pulmonary hypertension, it includes all the unclear multifactorial mechanisms. It can be, for example, systemic disorders, metabolic disorders, hematological disorders, and complex congenital heart diseases. So coming into the pathophysiology mechanisms, first we have increased pulmonary vascular resistance. So increased pulmonary vascular resistance can be associated with occlusive vasculopathy. It can be included hypoxic pulmonary vasoconstriction, which can be like a chronic condition due to COPD or obstructive sleep apnea. Increased pulmonary vessel pressure, which can be, for example, due to right heart hypertrophy and leading to cor pulmonale, and we will talk more about this later. It can be due to inflammation following, for example, COPD, or pulmonary arterial hypertension associated with endothelial dysfunction. The other mechanism of pulmonary hypertension is increased pulmonary venous pressure, which can be, for example, due to overload or pressure or volume overload, or pressure overload in the left side of the heart, which can be due to any valvulopathy within the left side, which means like mitral valve regurgitation. Increased pulmonary blood flow is also another mechanism in the pathophysiology of the pulmonary hypertension, which can be, for example, due to portal pulmonary hypertension or the presence of some congenital pathology like left to right shunts, which is present in atrial septal defects or in ventricular septal defects, for example. Now, let's talk about the clinical presentation of the patient. So generally, patients with an early pulmonary hypertension, they may be asymptomatic. If they are symptomatic, the common symptoms will include dyspnea and or syncope on exertion, which happens due to increased pulmonary vascular resistance, chest pain which doesn't respond to nitrates, fatigue, and cyanosis. Some less common symptoms include cough. It includes hemoptysis due to rupture of a dilated pulmonary arteriole. It can include hoarseness of voice due to left recurrent laryngeal nerve compression by a dilated pulmonary artery. On physical examination, we may hear a loud and palpable second heart sounds, often a split, jugular venous dissension, symptoms of right heart failure, nail clubbing, parasternal heaving, which is a heaving motion or impulse that can be felt with the fingers left to the sternum due to chronic contractions of the right heart against higher pressures. Now for the diagnosis of pulmonary hypertension, first we start with transthoracic echocardiography. So in transthoracic echocardiography, you have to check for pulmonary artery systolic pressure, mean pulmonary artery pressure, and right ventricular systolic pressure. Usually we find increased tricuspid regurgitation velocity and signs of pressure overload in the right ventricle, like flattening of the interventricular septum, signs of right ventricular hypertrophy, and dilation of coronary sinus. This can be also dilation and hypokinesis of the right ventricle, right atrial dilation, or problems within the diastolic function of the left side of the heart. Or some evidence, for example, of underlying cardiovascular pathology like left ventricular dysfunction, presence of valvulopathy like mitral stenosis, or thrombosis, for example, in the pulmonary artery. Right heart catheterization actually is the definitive diagnostic approach for pulmonary hypertension after high suspicion with transthoracic echocardiography. Of course, we have to use, or we can use actually another diagnostic uh, procedures like X-ray, BNP levels to check for heart failure, ECGs, VQ scan for checking for pulmonary embolism presence or pulmonary function tests. So let's talk first about the findings of the right heart catheterization, which is the definitive diagnosis. As I said before in the definition, the mean pulmonary artery pressure, it has to be more than 20 millimeter mercury at rest to be considered as a diagnosis for pulmonary hypertension. The pulmonary vascular resistance it will be more than 3 Wood units. The normal is between 0.25 to 1.6, and the capillary wedge pressure it should be less than 15 millimeter mercury. It can be also some signs of postcapillary pulmonary hypertension and mixed, like pre and postcapillary pulmonary hypertension, which is secondary to left heart disease. Now, on the ECG, you may find signs of a right ventricular overload, like right ventricular hypertrophy sign with right axis deviation, pulmonary incomplete right bundle branch block, S1Q3G3 sign, which is wide as like prominence as in lead 1, and prominence Q in lead 3, and inverted T wave in lead 3, which is also a sign that we can find in pulmonary embolism. We may see also signs of ischemic heart disease if it's present. Other investigations, they are based on our clinical suspicion of other causes, so it's based on each clinical case. We may check for arterial blood gases, for drug screening in the urine if we suspect that it's drug induced, some sleeping study if we suspect obstructive sleep apnea, liver function tests in case of suspicion of pulmonary hypertension with ultrasonography, and screening for infections if we suspect it with antibodies, for example, if we suspect connective tissue pathology, inflammatory markers, and so on. Now coming to the treatment. The treatment actually it depends on the underlying cause, but we consider like directed therapies. For example, in group 1 of pulmonary hypertension, the first line is calcium channel blockers and pulmonary vasodilators as the second line. They are not typically beneficial pulmonary vasodilators with group 2 and group 3 of pulmonary hypertension. If we have like patients with acute decompensated pulmonary hypertension, we have to assess for shock. We give oxygen if it's needed, diuretics for volume overload with attention to over diuresis. We reduce the right ventricular overload with pulmonary vasodilators, and we treat the cause. Surgery, if it's needed, it has to be performed. For example, it can be balloon pulmonary angioplasty for group 4 of pulmonary hypertension or pulmonary endarterectomy. Now, cor pulmonale. So, cor pulmonale, it's an altered structure, either hypertrophy or dilation, or its impaired function of the right ventricle due to pulmonary hypertension, resulting from a primary disorder of respiratory or pulmonary artery system. This can be either acute or chronic. So for acute, of course, it's a sudden increase in the right ventricular overload, leading to a right ventricular dilation and dysfunction. This can be either caused by an acute massive pulmonary embolism, which is the most common cause, or for example, acute respiratory distress syndrome. The patient will be having an acute onset with chest pain, shortness of breath, hypotension, syncope, for example. For the chronic cor pulmonale, this increase in the right ventricular overload it leads to a progressive right ventricular hypertrophy, which results over time to dilation and dysfunction of the right ventricle. It can be caused by diseases of the lung parenchyma like COPD or bronchiectasis. It can be caused by a chronic thromboembolic pulmonary hypertension. Disorders of a chronic hypoxia, for example, can be as well. Symptoms there will be similar to pulmonary hypertension in general and right heart failure. Diagnosis, of course, we will need echocardiography to check for right ventricular dilation, hypertrophy, or dysfunction. We have also to keep in mind checking the pulmonary embolism as a first diagnosis in case of acute cor pulmonale, because also the treatment depends on the cause. So if it's acute, first we have to stabilize the patient and then do intensive treatment of the main cause. And that's all for today. Thank you for watching. I hope this was useful.